the clinical presentation, when we say signs and symptoms, the characteristics of the chest pain, yeah, is usually squeezing, pressing, vice-like discomfort, usually in the substernal or left precordial region, with radiation to the neck, jaw, or shoulders, or even down the arms. Okay, so typically when we get patients, especially when I was in IJN, they usually describe it as a central chest pain. On the left is also possible. On the right is also possible. At the back, in between the shoulder blades, are also possible. But most of the time, it is a central retrosternal chest pain. Now, the chest pain is a pressing, a pressure. Patients will describe it as something heavy on their chest. Yeah, something sitting on their chest, a big rock on their chest, things like that. Or sometimes they describe a tightness, as though there is a rope around the chest, and that rope is being tightened and tightened and tightened. So it's a heaviness or a tightness of the chest pain. Now this chest pain tends to radiate to the shoulders, down the arm, up the neck, and even up to the jaw. Okay. Then they will get associated symptoms. Yeah? Associated symptoms such as shortness of breath, sweating, profuse sweating, and their profuse sweating tends to really soak them. We can even take off their shirt or their t-shirt and we can squeeze and we can get out sweat. That's how much they sweat. It's really profuse sweating, nausea, and sometimes followed by vomiting, and of course, as I mentioned just now, shortness of breath, dyspnea. So when you get these symptoms, the more symptoms you have, the more likely it is a myocardial infarction. Do an ECG, get troponin T if you have the facility there. Okay, AMI in known cases of coronary artery disease may present with chest pain that is increasing in frequency, yeah, or occurring at rest or unrelieved by KTM. These are the things that for patients who have already known coronary artery disease. Okay, so what do you do? What do you do when you get chest pain suggestive of ischemia? Apart from doing the ECG and the troponin T, you have to start immediate treatment. Yeah, so what we do usually, the normal things for when you do assessment is your vital signs, measure the oxygen saturation, get your IV access as soon as possible, then your 12-lead ECG, brief targeted history and physical examination, serial cardiac enzyme markers, but get the initial enzyme markers, and then other investigations as appropriate. And then you start your immediate general treatment. Usually what we say here, as you see at the bottom here, is MONA greets all patients. So MONA is M for morphine, O for oxygen, N for nitroglycerin, and A for aspirin. Okay, so keep your aspirin handy at your clinics, at your consultation rooms. You can always give immediately 300 milligrams of aspirin. Okay, if you have any other antiplatelet, you can also give that. We give an anti-double platelet treatment at the beginning. Give them some oxygen, run at 4 liters per minute. If you have nitroglycerin, sublingual or spray, and then some form of pain relief, which you can use morphine or pethidine. It depends on what you prefer. Okay, so then we look at the ECG. Okay, so this is a normal ECG. Just to remind you again, there is the P wave, PR interval, QRS complex, followed by the ST segment, and then the T wave. Okay, and sometimes you may see a small U wave after the T wave. Okay, so when we look at ST elevation, what we want to look at is the ST segment is elevated. But what is important here is the J point, which is where the end of the QRS complex meets the beginning of the ST segment. Yeah, as seen is this diagram here. So this is the J point. This J point must be elevated before you can say that this is ST elevation. Okay, right. So looking at this example here you can see obvious ST elevation where the J point is raised above the baseline. All right, so this is the P wave to T wave baseline. Okay, and this is the J point which is elevated. So generally what we look at is the ST elevation of more than 1 millimeter in two contiguous limb leads. Okay, when we say contiguous limb leads, it means leads that are associated with each other. So limb leads are basically 1, 2, 3, AVR, AVL, and AVF. Those are the limb leads. Okay, So in two contiguous limb leads, that means leads which are associated to each other, which we will mention a bit later in this lecture. And as the elevation of more than 2 millimeters in two contiguous chest leads. Okay, so chest leads are V1 to V6. All right. So now just to highlight a bit on this term contiguous, yeah, we are not talking about continuous, yeah, which is a bit different. When we say it's a continuous limb lead, then it's 1 and 2 and 3, or AVR and AVL, or DF, or 2 and 3 and AVR. No, that is continuous, yeah. But we are talking about contiguous. Contiguous means that it's a relationship, meaning that when we look at lead 1, we also look at lead AVL. Yeah, when we look at lead 2, we also look at lead 3 and AVF. That's what we mean by contiguous limb leads. Now, what is the relationship of the contiguous limb leads? We shall also cover a bit later in this lecture. An elevation of more than 2 meters in two contiguous chest leads. So chest leads will be from V1 to V4 or V5 and V6. These are contiguous chest leads. All right.